All right, let's try to end this on a positive note by talking about Clostridium difficile, one of my favorite bacteria. And so this is the bacillus that you're looking at, and it is producing toxins, toxins A and B, and they are very dangerous. It's one of the most common infections you can get at a hospital. So Clostridium difficile, short for C. diff, it's a spore-forming, gram-positive, which just means it has a thick cell wall. Bacillus, it was initially detected in 1935, which was very surprising to me that we've had all this knowledge about it for so many years. So it wasn't until 1978 that it was thought to be non-pathogenic, when Bartlett et al. Identified C. diff as the source of the cytotoxin in the stools of patients with colitis. So let's talk about, I think, the most important part of C. difficile infections are the role of antibiotics. So your guts, your intestines, your stomach, they have millions of bacteria, including your stomach too. It was long thought that the stomach was totally free of bacteria, that it was just too acidic to host any type of bacteria. That's no longer considered to be true. When you take an antibiotic to treat an infection, like all of us do, at least one time in our life, usually the drug destroys all kinds of bacteria, good and bad. And without enough, quote, healthy or good bacteria, your gut microbiome is at risk. So microbial diversity, this is something that I've actually done some research on. And what Kevin didn't note is that I'm a research scientist, and I'll also be sharing some of my own research on this. So diversity in your gut is remarkably important. It's good to have all kinds of bacteria. Any disruption or deviation of diversity could lead to colonization of new organisms. And just because you're colonized with Clostridium difficile doesn't mean you'll actually get an infection. Just because you have a colonization of Streptococcus in your throat doesn't mean you actually need antibiotics. So there's a great deal of overdiagnosis. So antibiotic initiation is more difficult. It's a more difficult judgment than we think it is. So antibiotics seriously disrupt the biodiversity of our microbiome, which is the sum of all the organisms in our gut and their interaction. And just in case you all don't know, we have more bacteria on and in our body than we have human cells. So we are more bacteria than we are humanity. And let me give you the process associated with a C. diff infection. We all have a normal bacteria, and this is in the top left. And that normal bacteria has a great deal of colonization resistance. And whenever you introduce antibiotics, you lose some of that. And then you have a susceptible microbiome or susceptible microbiota. And on the top right, you have Clostridium difficile spores. And those can either be introduced. Usually you get them by not washing your hands, or you pick them up in hospitals. It's called the fecal oral route. Or you could also have a colonization in your gut of Clostridium difficile, and whenever you introduce the antibiotics, it disturbs that balance, and then you can get an infection. So you have the C. diff spores are introduced somehow into your body. They germinate. That creates vegetative C. diff, which then produces toxins A and B, and then you have the toxin production. Now, from here, one of two things can happen. You can totally clear it, or you can become infected. So the red individual, that is an individual that has a C. diff infection, or CDI. So what happens from that point is you usually treat it with antibiotics, and either they recover, or they have recurrent CDI. So you have a recurrent Clostridium difficile infection. And then the second route, and this is where my research comes in, is you can have a fecal microbiome transplant. And the same thing can happen. You can either recover, and almost everybody recovers. By the way, this this is kind of a miracle treatment for people with recurrent Clostridium difficile infections that have failed vancomycin. Vancomycin is a well-known drug that treats Clostridium difficile. So the fecal transplantation is something that's been around for a very long time, and it has close to a 90% cure rate of Clostridium difficile infection. But it's really only used for recurrent Clostridium difficile infections. And then you have a recovery of your microbiome. And by the way, it's not known how long it takes for your gut to actually recover its resistance, its colonization resistance. It's been said to take years, 3 years to go back to a healthy microbiome. So some of the symptoms, you have diarrhea, colitis, and really this stuff spreads like crazy in a hospital, and that's why contact precautions are enormously important. Once established, C. diff produces spores. It attacks the lining of the intestines. The toxins destroy the cells and produce patches or plaques, and decaying cellular debris inside the colon can cause watery diarrhea. So all of this stuff can infect everybody else in the hospital and in nursing homes or anywhere else. So because C. diff is shed in feces, any surface or device that becomes contaminated can serve as a reservoir. And it can take up to 5 months for C. diff to die and dry. So it persists in the environment for a super long time. It's a really hardy because it's a spore-forming bacillus. So people get infected by touching the surfaces that may not have been cleaned. Healthcare workers can spread it from person to person. And you're at risk of getting an infection if you have an illness that requires prolonged use of antibiotics, and usually these occur in nursing homes or long-term healthcare facilities. Usually the initial treatment is with antibiotics, though. The fecal transplant isn't really done until you have a recurrence of CDI. So this is considered the bundle approach to the prevention of C. diff. Of course, hand washing, not just with alcohol, because alcohol actually doesn't kill the C. diff. You have to use soap and water. What else? Contact precautions. The people with C. diff need to have a private room, and if not available, to share a room with someone who has the same illness. Hospital staff have to wear disposable gloves and gowns while in the room. This is super expensive, and it takes a long time as well. So you can imagine the rates of adherence to contact precautions. Also, sometimes patients really don't like it either. You're kind of dressed up all the time and interacting with them that way. And then you have to have thorough cleaning. One of the only things that kills C. diff on surfaces is bleach. And the most important thing really has to do with antibiotics and overprescribing antibiotics. And that's probably the most important way of preventing C. diff. So just some epidemiology. It's one of the most common healthcare-associated infections in the country. 500,000 people get sick each year. In recent years, C. diff has become much more virulent. And currently, the new strain of it, which is BINAP1027, is incredibly virulent, producing way more toxins, toxin A and toxin B. And as you can see, C. diff has increased dramatically since 2000 for people who are, this is mostly among people who are older, but it has increased pretty much for everybody over the age of 45. Elderly hospitalized patients receive antibiotics are really at the greatest risk for an infection and mortality. However, and this is really striking, is that there's new evidence that shows that CDI in younger populations with no previous contact with hospitals or with antibiotics are getting the infection, and that's kind of crazy. The incidence of infection in other groups previously considered at low risk, such as children and pregnant women, has also increased. Some of my research is focused on recurrent CDI. And so we know that up to 40% of patients suffer from a recurrence of CDI following standard antibiotic treatment. It may seem ironic that C. diff infections are treated with additional antibiotics because normally you get an infection because you're treated with an antibiotic. So like I said, one of the ways you can treat a recurrence is with fecal transplantation. And this is how some of the media has portrayed it. When a pill fails, this option provides a cure. And fecal transplants cure C. diff infections when drugs can't. So this is one slide from some of my research and my colleagues. We gave a fecal transplant to 14 of our patients who had a recurrent C. diff infection. And since 12 participants remained asymptomatic throughout the study contact, we considered fecal microbiota transplantation to have an 86% success rate or 86% cure rate. This is a real, I know the conference is a lot about doom and gloom, but I think this is one piece that is quite exciting. And what's also interesting is that your gut microbiota, the fecal microbiota of recipients following the transplant was more diverse and more similar to the donor profile than the microbiota prior to transplantation. So here are all of the treatment options for recurrent C. diff. You can have, typically they start with vancomycin, and then 60%. And for first recurrence, the effectiveness of antibiotics is around 60% and declines afterward. Then you have the fecal transplant. That's roughly 90% success rate or cure rate. And then there's probiotics, which still haven't totally been studied well, but I think there's some promising literature showing that taking probiotics could also help. You know, really, I think the best way to reduce any type of C. diff infection is by reducing unnecessary antibiotic usage. I won't talk about this a lot because we've mentioned it a lot already today. And however, like I said at the beginning, this isn't altogether clear. So it's not totally clear as whether or not they should have antibiotics initiated on them. So it's a little bit more complicated than we think, the antimicrobial stewardship. So that's it. I just want to end with that. Thank you all very much for your time.